Okay, hi everyone. My name is Clint Dowland, and today I'm presenting our paper, Ontology-based integration of consumer data and EHR systems to fill gaps in social determinants of health data. And I want to go ahead and thank my co-authors, Melody, Sadipa, and Matthias for their contributions on this paper. I thought I only had 15 minutes, so I've actually cut a lot of things out of this that I might have included were it 25 minutes, but we were told 15 for the short papers.
Yes, thank you for update this information. 15 is the correct.
Okay, thank you. So here we have some examples of social determinants of health, and we're talking about social determinants of health. What we mean are social conditions that can influence health, to put it simply. And some of them have more direct influences on health. Some of them are less direct. And when they have a harmful influence, they're sometimes also called social risk factors. So, for example, income level can be considered a social determinant of health, whether it's high or low, because it might positively or negatively affect health. But when it's low and it has negative effects because of that, then it could also be called a social risk factor. And one thing that we see when we look into social determinants of health is that they're not just a matter of discrete causal pathways from social conditions to health effects. Instead, many social determinants of health affect other social determinants of health. So they form sort of an interconnected web of causes and effects. And here's a very, very simplified causal loop diagram of some social determinants of health and how they are interrelated. And so if you're not familiar with causal loop diagrams, to put it kind of simply, the black or positive arrows, those correspond to a positive correlation, but with an underlying causal influence that goes in the direction of the arrow. And similarly for the red or negative arrows, those represent a negative correlation, but where the causal influence flows in the direction of the arrow. So it's sort of a correlation with an underlying cause being understood. And as for the nodes, these are all things that could be considered social determinants of health. I've made the ones that are more closely, more directly affecting health, purple, to make those stand out a bit. And so again, this leaves out a lot of types of social determinants of health, but it's a simple example of how they create these sort of causal webs. And if we follow the paths through these, we can see that in some cases, some sets of nodes together form self-reinforcing cycles, such as access to transportation, and the way it affects access to job opportunities, which in turn can affect income level, which in turn affects financial strain, which can affect many things, including access to transportation. So for any of those four, we can follow that path and get back to where we started. So we have this sort of self-reinforcing cycle. So with this sort of interconnected network of factors in mind, I took the following approach when beginning to develop our social risk factor ontology. I began with 19 literature summaries on different areas of SDOH because each brings together findings from several different other sources. And from these, I extracted 809 assertions about causal relations or correlations between pairs of phenomena, such as a pair of social conditions or a social condition and a health condition. And I identified the common elements in these because many of them came up more than once, but they were described with different phrases or denoted with different phrases. And so I worked towards making the phrasing uniform. Many of the relata were scenarios involving multiple entities, and so those needed to be analyzed to some extent or modeled in order to yield the additional classes and relations that would be needed to represent those types of scenarios. And of course, where possible, we imported matching terms from other ontologies, and then everything was arranged, or in some cases is still being arranged, into a BFO-based hierarchy. So on the data side of things, we're working with commercial consumer data as a resource to provide us with SDOH-related information things that, for example, might not be in the EHR or might not be captured in the typical sorts of screening tools that are used for SDOH. And so these data are initially gathered by the marketing companies for the purpose of predicting spending habits, but it turns out that some of them are informative about SDOH. And we are working with data from a particular commercial database marketing company, and we're reviewing the 6,260 data elements in their database. And so one of the goals of this project, which was already a goal before I was brought in to do ontology related work on this project, was to create a pipeline for consumer data about SDOH into EHR systems, and thereby giving providers a more robust picture of a patient's social conditions that doesn't require more extensive questioning or using a longer questionnaire or additional questionnaires, for example. And more broadly, the goals are to identify SDOH relevant consumer data, and also to enable the integration through the ontology, enable the integration of SDOH data from disparate sources. And here's a small set of examples of SDOH related data elements that are found in the consumer data. So there's information about employment status, the occupation of the person, and as well as the education level. And for both occupation and education level, they have data elements both for the person that the data set is primarily associated with, and up to 4 other members of the person's household. There's also data on primary language, the household size, the number of vehicles owned, the bedroom count of the home, the room count of the home, the square footage, and there's also information about whether the home lacks heating or lacks cooling. And so I want to talk about a couple of particular types of examples. I won't be going through all of these, but I wanted to focus on language use and overcrowding. So let's start with language use. Language barriers and linguistic skills, limited linguistic skills, that is, can have detrimental effects on health. And one way they can do so is by being obstacles to understanding a healthcare provider's questions and conveying problems to them, because that can inhibit the provider's ability to reach an accurate diagnosis. And they can also be obstacles to understanding health-related information, either from the healthcare provider or from public sources. And so, as I mentioned a couple of slides back, primary language is something we have data about in the consumer data. And just to clarify, by primary language here, we mean the language a person is most comfortable using or most skilled at using. And the way we've modeled the relation of the person to the competence and to the language is based on the OMERS approach to representing languages and linguistic competences. So the person is a bearer, is the bearer of the linguistic competence, which is a member part of the Spanish language, which is an individual entity, and it is an instance of the class OMERS language. And so we've represented the primary language data item as being about the person, the competence, and the language. And so if we are integrating this with EHR data, then from that data, we might have, for example, a preferred language data item. And while primary language is the language the person is most skilled at using, preferred language is sort of contextual, and it's the language that a person has selected to use in the context of a certain interaction with someone, a certain communication process, in this case, within the context of a particular healthcare encounter. Now, preferred language isn't always a language that the patient has a competence for. In some cases, they might be forced to choose a language they don't have a competence for and use some method of translation. So we can't assume that there is a competence for this, but we can represent the preferred language data item as being about the person, about the encounter, and about the language. And again, the language is an instance of OMERS language. So now we've got a couple of common elements here, the language class and the person. And then we can also get additional information related to this built into an ontological representation. And so we could make use of for example, the OMERS language individuals file, which has several languages represented as named individuals and as instances of OMERS language. And here I've supposed that we've gone a bit further and equipped that with relations between pairs of languages, such as whether languages are mutually intelligible or not. And in this case, they are not. If we wanted to get more fine-grained, we could include dialects as parts of languages and represent intelligibility-based relations amongst the dialects as well. And so by transforming the consumer data and the EHR data into this ontology-based format and a one consistent format, we've got information coming from 3 different resources that we can easily combine into one more robust representation of information about person P2's language use, both in general and within the context of a health-related experience that the person had, a particular health encounter. To save time, I excluded some other language-related data from the consumer data, but they do also have some one data element for which some values can be indicative of limited English proficiency. So that could help us see more closely whether there might actually be a language barrier here. We can't assume there's a language barrier just because the primary and preferred language differ, because this person might be very skilled at using English. But we do want to be aware. It would be good to be aware of cases in which there is a language barrier during a healthcare encounter. Moving to the next type of example, I want to talk about household overcrowding. So this occurs when you have too many people sharing insufficient space, and just how to describe what's insufficient can vary from one approach to another. So researchers have measured it in different ways, such as the persons per bedroom or persons per room in general, where maybe above some threshold they say that the people are experiencing overcrowding. And some researchers have also used the approach of measuring it by square feet per person, where if it's below some threshold, they'll say the household is experiencing overcrowding. And some examples of negative outcomes that are associated with overcrowding are stress, infectious diseases, and food insecurity. Now, in some cases, these might not all be populated with values for a given individual. But as long as the household size is available and at least one of the other 3 is available, then at least one of the approaches to measuring overcrowding can be applied. And for example, if there are enough people for whom all of these values or all of these elements are populated with values, then in principle we could, or someone could, use that in a project that looks into which approach to measuring overcrowding is the best predictor or most strongly correlated with the sort of negative outcomes associated with overcrowding. Just one example of something that could be done with that. And if we represent the types of measures themselves within the ontology and represent these types of data items as their inputs, depending on which type of measure it is, then, for example, we could do a query to see which overcrowding related values are available for a given person. So it's helpful to have these things organized and relate them to overcrowding measures in that way. And so, sorry, I think I should have skipped to this slide already, but yeah, those are the overcrowding related consumer data elements we have. There's additionally the number of adults in the household and number of children in the household, which matter for some of the more complex approaches to measuring overcrowding that distinguish between adult and child members of the household. But here's a simple example of how this would be represented. So we got a data set about person P1, who's a member of a household that resides in a shared home. And here the consumer data is telling us that the person's household size is 6, so 6 members of the household, and they're sharing a home with only 2 bedrooms. And so if we're looking into the persons per bedroom count, then of course we easily infer an additional data item, persons per bedroom data item with a value of 3. And then if someone is employing the 2 persons per bedroom cutoff point, then from that they could further infer that person P1 is characterized by certain clinical codes, such as the SNOMED CT code for overcrowded in the house, or the ICD-10-CM code for inadequate housing. And so now we've gone from the consumer data to clinical codes that are used, for example, in fire SDOH data sets. And let's see, in closing, I just wanted to mention some continuing and future work related to this project and this presentation. So we want to continue further to develop Surfon and eventually make it publicly accessible. It's not there yet, but we're working towards that. And of course, we want to continue developing the pipeline of social determinants of health data from consumer data into EHR systems. And finally, we'd like to, we'd like to make use of Surfon as the basis for an additional ontological representation that would include the sort of causal interrelations amongst SDOH that we saw earlier in the causal loop diagram, but of course, taking account of more types of relations, getting more fine-grained instead of just these broad descriptions of types of scenarios, and using more specific relations than just the positive and negative effects. All right, so I will wrap up there and see if there are any questions, and thank you all very much.